The title of the presentation slightly changed a little bit, and we're really going to be talking about compounding and manipulating medicines, and really focusing on the risk assessment and the risk management, I guess, and as Catherine says, some of the best practice issues. And looking at the list of participants, I really feel quite sort of a bit overstated to be an expert in this area, because whilst I've been interested in this area for quite a long time, I don't actually currently work in this area of practice, and you know, it's just I guess it's a passion that's continued through for many years, and first surfaced when I was working in the Middle East, when there was actually a lack of drugs for children. We had to do a lot of compounding, and really there wasn't much information available, so it really followed through from that and has continued. And just a quick word about eMixed that Catherine mentioned. It's probably a little bit dated, but it will be going through a bit of an overhaul in the next few months. So if you check it out and think, well, you know, that's it needs a bit of work. It does need a bit of work, and we'll hope to actually surface that in the next few months. So an outline, and I think the way I'll run this is that I'll try and keep to time so to allow perhaps 15, maybe even 20 minutes at the end of the session for some questions. And I think you've all got copies of the slides. There's quite a bit of detail in some of the slides. Some of the slides I'll probably just make one or two quick points, and the rest you can keep for your records. And as Catherine says, also if there's follow-up issues from this webinar, then you know, we can make the blog quite interactive after this session. So I'm going to talk about some of the risks, and I'm sure that most of you listening will be familiar with some of the risks, or most of the risks associated with compounded formulations. Risk assessment and putting those into various categories. How we manage, and part of the risk management, I think, is identifying the high risk compounding and looking at alternatives which may be suitable, more safer alternatives in some cases, and then some overall risk management or minimization strategies. Just quickly, I think we're all familiar with this terminology, make medicines child size, and there's quite a, you know, we've got quite an international group participating in this webinar. I think we'd all agree that this issue of you know, medicines and availability of medicines, lack of availability, is a global problem, and you know, it's different in different countries. So we see, say, a lot of developing countries which are burdened by a lot of infectious disease, and even now we struggle to get pediatric medicines, children's medicines available for a lot of those diseases. So the access and availability is quite variable in different countries. Again, I'm sure you're all familiar with this terminology, but just very briefly, we're talking in terms of off-label use, where we're prescribing outside the terms indicated in the product license. And then we're talking about unlicensed use, where we're modifying the formulation, and this really sort of falls into the realm of extemporaneous preparation. And just quickly looking at some of the categories there in unlicensed use, these would be modified formulations, extemps, could be imported medicines, and even chemicals used as drugs. There's a lot of detail on that slide, and I won't go into the various figures, but the idea behind that is to clearly demonstrate from studies that have been done through the years, and I think a few of the participants are actually authors of those studies, where we can see that the extent of unlicensed and off-label use is very big, is very large in pediatric settings, and especially in neonatal intensive care, where that one particular study showed, you know, 65% of prescriptions unlicensed or off-label. General pediatric wards across Europe, quite extensive use as well. So even in general practice, we find quite widespread use of unlicensed and off-label medicines. So many medicines given to children are off-label or unlicensed. And really, you know, the catchphrase is that we compound the problems We've got various factors coming into play there. We have lack of evidence of effectiveness. We know various studies have demonstrated that off-label and unlicensed use of medicines is associated with an increased risk of adverse drug reactions and adverse drug events. We've got the added complexity and worries and concerns about dose calculation errors with medicines in general, but when we're dealing with particularly with potentially toxic drugs, narrow therapeutic index drugs, then that risk increases. Big concerns about quality and safety. I think we'd all agree that with most compounded medicines we have a lot of concern about the quality and safety, and especially what happens to that formulation when it goes out to the patient's home, because we have no control over the storage and how the drug is administered as well. So the bottom line there really is that we give the riskiest medicines to the most vulnerable patients. So looking at some of the risks associated with compounding, and I'm really talking in the context of oral liquids made from tablets. That's the main, I guess, the main situation that we would come across. So, and this is based on, I don't know if people have seen Mark Jackson and Andrew Loy's book, which is, I forget the title, I have a slide of it later. Mark is a former colleague of mine. He worked out in New Zealand a few years ago, and this book is actually a very good resource for this particular subject. And really, you can break up the risks associated with compounding into these three areas: the technical risks, the clinical risks, and even environmental and personal risks when we're dealing with things like drug powders, cytotoxics, the risk to the operator. So some of the technical risks, we could break this down, and this is a problem I think that we commonly encounter in practice, is, is there a validated formula? And even if there is a validated formula, can we extrapolate that formula to the situation we're dealing with? I'll talk a little bit more about that shortly. But further technical risk would be physical instability problems. I think we've all seen those occurring with suspensions that with either compounded ourselves, or we encounter a patient brings into hospital and we see clearly problems with and potential physical instability problems, lack of resuspension and things like that. And then of course we've got our chemical instability. In the whole scheme of things, we actually, I think we put a lot of emphasis on chemical instability, which certainly is a problem, but I actually have an opinion that the physical problems and the effects of excipients I've got on the bottom line there are actually bigger problems. There's more and more studies coming out showing that excipients in tablets actually do influence the stability of an active pharmaceutical ingredient quite markedly, which brings us into the situation where if we're dealing with different brands to those done in the original study, we may in fact be getting a different result, which is a concern. That's pretty much a large driving force really for using the API, but of course we don't always have that available. In fact, in most situations we don't. Validated formula, well, is the information available? Can the quality and safety be assured? Can the product be prepared from first principles? So, if we don't have that validated formula, that's the sort of things we should be looking at and considering. But I think this other point is something that's, I think there's an awareness of it, but perhaps not enough awareness in that, most of the studies on extemps, or let's say compounded products, I was trying to move away from that term extemp, because nobody really outside pharmacy understands what extemporaneous means. But most studies on compounded products, say prepared from tablets, probably about 90% of the ones published in literature are actually prepared in Aura Plus. And some of those studies are fair enough. Some of them lack a bit of depth from the scientific point of view. But I think the main concern there is that if that's our evidence base, what do we do in different settings. We've only just got Aura Plus in New Zealand, and it took quite a large lobbying to our government buying agency to actually fund Aura Plus. The situation there is that we have these studies in Aura Plus. It's difficult to extrapolate that data to a situation where we may only have, well, a different type of suspending base or syrup. And I've been in some countries where you can't even get syrup unless you actually prepare it, from raw sugar. So there's some problems, not just with availability of the pediatric medicines ready prepared, but also for the ingredients. And, to some extent, and this is no criticism because, Paddock, that lab have done a great deal of work to improve the information access in this area, but it would actually be quite good if the studies actually did some, there were some parallel studies which used more simple and more freely available bases so that they can be extrapolated more in practice. That's just a little bit of a personal issue I've got there, I think. If we look at physical, excuse me, physical instability, what are the considerations there? Well, I've come across many situations where pharmacists are working away and they're trying to produce an elegant suspension and trying to get hold of the ingredients. And in fact, the drug is soluble, so you might sort of question, well, do you need that in that situation? But if we've got an insoluble drug, does it resuspend? Do we do those sort of tests? And those tests are done in some of the studies, but bearing in mind that the ingredients might change, situations might change in practice. So I think we've really got to follow up what we make and look at how they behave in practice, and even encourage patients or their caregivers to report problems they encounter when they take them home and use them, because they could behave quite differently. Change of pH is a problem as well, in that I've come across situations where what is thought to be a solution has been prepared with phenobarbital sodium, nicely soluble. But if you change the pH by putting some syrup in there with good intent to make it taste nice, the syrup drops the pH and you get a precipitate of phenobarbital. Now that could be potentially hazardous, because what we think might be a solution then turns into a suspension with obviously dose uniformity and the potential for overdose. And as I said before, the tablet excipients can affect the physical properties. Just thinking of a couple of examples, and I'm sure people can relate to these. Years and years ago, I remember trying to make up a suspension using norfloxacin, and actually it set like concrete, whereas other brands were fine. Amiodarone seems to be notoriously problematic in suspension, in that I think there's some interaction between the active pharmaceutical ingredient and some of the excipients in the tablet, and it actually forms a very thick and difficult to use product. So that's the point there, is that we're dealing with different brands of tablets which have different excipients, can affect the physical properties and, as I mentioned before, the chemical stability as well. So chemical instability, well, I think we make the assumption, and this usually follows, that suspensions generally tend to be more stable than solutions. That's not an absolute, but it seems to be intuitive that that would be the case. Not always the case, but a generalization. We can certainly, we can do a little bit if we don't know, if we're dealing with a situation where we don't really know much about the stability of the drug. Some of the basic references will give the pH range of maximum stability. The vast majority of drugs seem to be in the sort of the acidic range, anything from 3.5 to 5, but that doesn't mean to say we always aim for that pH for maximum stability. But my point there is that we sometimes can find out a little bit about the stability profile of the drug that we're dealing with. And then we've got obviously our problems with oxidation and reduction. And yeah, it's quite difficult to find this information, and I guess, you know, the best practice really is trying to avoid situations where we really have concerns about chemical instability, because if that's the case, and we do have those concerns, we really should be looking at an alternative. Yeah, I've got tablet excipient effects there as well. I've mentioned it several times, so I think I've made the point. Yeah, what about the clinical risks? Well, there's been some recent studies done, I think through the Commonwealth Pharmaceutical Association, done in various countries, including Africa and yeah, throughout the world really. And one thing that popped up there, which is a little bit of a concern, is the quite widespread international compounding of digoxin. And that's obviously due to a supply problem. Now that seems really quite bad, that pharmacists, health practitioners are being put in situations where they're having to compound digoxin liquid from tablets. I mean, could they be using an alternative? Can they somehow, you know, I don't know, it's difficult to break a very tiny tablet. So digoxin liquid is widely available. So, you know, that's the issue, is that if pharmacists actually lobby and say this is a high-risk product, we shouldn't be compounding that, we should get the regulators to register this and get this in the country, then that's part of the battle. But you can imagine the potential problems with preparing a digoxin suspension. You know, obvious problems there with the physical characteristics and the possibility of overdoses and things. So, yeah, generally, if we're dealing with the narrow therapeutic index drugs like warfarin and anticonvulsant, then, you know, obviously these are going to impart more risk to the product that we're producing. So there's clinical risks in conjunction with all the other risks, would actually be able to build up a risk profile for that particular drug, so that then we can prioritize the drugs that we need to find alternatives for, and preferably commercial products that we know have been through a rigorous testing procedure. And I suppose, you know, one issue here is from the clinical risk assessment point of view, you know, how important is the drug. So, you know, if the drug is being used for, say, cardiovascular disease in a neonate, we might, you know, need something like captopril, then that comes into the equation. We really need that drug, so we need to make sure that we've got the lowest risk product available for that situation. Just quickly on, which is, I suppose, reasonably obvious, is that, you know, depending on the situations that compounding is occurring, then there's the possibility of the operator introducing problems into the formulation. And, you know, the risks of microbial or microbiological contamination are very rarely addressed in studies. And of course, the studies are done in really sort of well-controlled conditions. In-use situation is very rarely checked. So we're dealing with situations where, you know, there's a great potential to introduce microbial contamination into the product. The efficiency of the preservative systems are not always checked. There may be inadequate preservatives in there. And in fact, you know, in some settings, you know, and we've got concerns about preservatives as well. So in some settings, the preservatives aren't used because the pediatricians may consider those risky. But then we've got to sort of balance the risk of an unpreserved formulation versus a small amount of preservative in the formulation, which may be needed to prevent microbial growth. And that's the point there. What happens when the product is in use? In most situations, we don't know unless we actually follow up and find out, or we simulate what happens with those products, particularly if it's something that we've not actually produced before. I think it's very important from the point of view of microbiological, physical, chemical, we may not be able to do much about without you know, the lab availability, but with microbial and physical we can, I think, get an indication of how that product behaves in use in the patient's home. And we should be pointing out, we should be open about the potential risks to the patients and caregivers and ask them to actually report any problems they see in those formulations. And then we can work on the risk management side of things. And then obviously there's the potential for risks to the operator or the patient, and we're dealing, situations where there could be sensitivity to antibiotics and risk from cytotoxic drug exposure. Okay, just some examples here of high, medium, or low risk. And I think, why do we assess the risk? Well, I've probably pretty much covered it in what I've just said, but I think it identifies areas where practice can be improved. So if we're in a hospital setting and we're producing a range of products, actually quite a good exercise. And I recently did this with a pharmacist who'd just been seconded to work in the Pacific Islands, and she came across a situation where the hospital had been producing a range of pediatric liquids over a period of years, and the formulas were pretty much set in stone, but we actually worked through and identified the ones which we thought were the riskiest products, and we actually focus on trying to get those in commercially to sort of reduce the overall risk. So it identifies areas where practice can be improved. It identifies risk management strategies. It prioritizes the need, spelling mistake there, for alternatives to compounding, especially if high risk. And that's the book I was talking about. That has a risk assessment matrix. Oh, another spelling mistake. Yeah, that's. I think it's still in its first edition, and it is really quite a good guide. It gives a series of monographs where it goes through, and there's a little bit of subjectivity here about which are the risky products and which are lower risk. I have. These are actually not the criteria that they've necessarily used in this book. These are some thoughts I've got of my own, because I think it builds in a few of the factors. But these are not cast in stone, and I think you can develop your own criteria to identify which would be high, medium, and low risk. So this is a high risk example. So this is a formulation assessed at high risk and some example criteria. So it could be from a technical perspective, no validated formula. If it's an insoluble drug and it's difficult to resuspend, if there's a risk of precipitation. High risk, obviously, narrow therapeutic range. It's actually an essential drug in widespread use, and there's concerns about bioavailability. So that would be one set. Low risk, well, good quality published study, wide external validity, so we can apply the results of that study into different practice situations. We've got good indications that the drug is stable in solution, and it's a wide therapeutic index, and bioavailability doesn't seem to be an issue. And intermediates, well, maybe the published study has got some concerns. It's not a particularly robust study, but at least we've got some information, good general stability information. And maybe we've got some clinical concerns, but not enough to put it into the high risk. So I'm just throwing a few ideas here that some people might be able to take into practice. So there's a couple of examples here. I've actually mentioned these, but phenobarbital I mentioned, but there was also a situation, and I think this was published in the literature as well, with flecainide, where flecainide was being prepared as a solution from tablets. Obviously, this is a narrow therapeutic index drug. It will be classed as high risk, and it has, depending on what tablets used and how it's actually compounded, there was a risk of precipitation, and there were cases of babies receiving overdoses of flecainide because what had happened is that the drug had precipitated out and actually collected down at the as towards the end of the bottom of the bottle. So baby's got a big dose towards the end and probably nothing in the first few doses. High risk example, I think amiodarone fits into that. It's really quite tricky to make. unless you use the right sort of bases. Narrow therapeutic index, and as I say, the studies are really quite all over the place, and the suspension really is poor and variable physical characteristics. Here's a medium risk one. Captopril. There are some good quality studies, so we actually have quite a good range of studies to look at, but there was a study done in the UK, and I think the authors in the participants as well, where it actually showed that, it's just by way of passing here, that I think there was about 12 different versions or formulas being used in the UK. And one point I'll make at the end is to actually get within a country setting, within a setting, to actually get uniformity in preparing an agreement on the best practice for a particular formulation, then I think that is a good risk management strategy as well. But Captopril, yeah, it's good quality studies. It is chemically unstable. It's in solution, so there shouldn't be any problems with dose uniformity. So I'd say that's probably medium risk. And then low risk, well, trimethoprim, it's got a wide therapeutic index. Generally it seems to suspend well. There are some supporting studies. So, people could argue, but it's just some examples that I've thrown up there for people to look at. Well, we're not going to talk. I think this is the subject of one of the previous webinars, but of course, in any risk assessment of a formulation, we're not just considering what we put in as far as the tablets and the suspending base. There's also the excipients. So, there's a possibility that we might introduce something in there, hopefully not ethanol, but ethanol, of course, is in quite a lot of commercial preparations. We need to consider the possibility of risk to the patient as well. And you may well have seen this slide before, but this is looking at the overall exposure to propylene glycol. I think it is, yeah, propylene glycol in a neonatal unit. So, I mean, the upshot of that slide is that the dotted line is the accepted WHO recommended limit for adults, and you can actually see in milligrams per kilogram per week, and you can see that there was quite a lot of excessive exposure to propylene glycol by neonates in that particular study. Right, some alternatives to compounding. Just checking the time. Yep. Okay, so again, I think people will be familiar with these, but I just want to put these into the context of, we don't, sometimes compounding may be safer than an alternative that we sort of focus on. So, sometimes it's not always that compounding is the riskiest. We've actually got to consider everything, the whole scenario, the risk of compounding versus the risk associated with tablet dispersion or tablet splitting. And it is quite tricky because sometimes we don't know all the answers. In fact, most situations we don't know, so we've got to take a best practice evaluation, if you like. So there's quite a list of alternatives, and I obviously don't have time to go into detail, and I want to leave some time for discussion. But yeah, that's a great one, isn't it? The first one. If we had access to an age-appropriate product, that would be the first thing to go for. Something that's not always considered is looking for a therapeutic alternative. So sometimes, as pharmacists and as pediatricians and any health professional, we go down the track as that we must use that drug. But if there is an alternative drug that has similar therapeutic properties that is available in a safer, that could be a safer compounded form or a safer presentation to the patient, then we should choose that. Tablet crushing, tablet dispersion, splitting tablets, dose rounding and dose banding, using the injection orally, and finally an alternative to the oral route. So just some quick thoughts on those. Therapeutic alternatives, is a similar drug available in a more appropriate form? So it could be a commercially manufactured liquid, or it could be an alternative that can be more easily dispersed or crushed. Really, it's just an equally or more effective, safer, and more reliable alternative compounding to compounding that can be found. So here's some examples. Really, enalapril, is prescribed. Now we know that in some situations there is a commercially available captopril, and maybe the data, maybe the captopril tablets actually disperse much more easily. So I know that there may be situations where enalapril may be preferred for therapeutic reasons. It's obviously a longer half-life, but it's something that we can discuss with the prescriber and come to an agreement and say, well, on balance, captopril may be a better option because it's got a more reliable dose presentation. Yeah, nifedipine. Well, I was actually quite surprised that I won't mention the hospital, but a major hospital in a Western European country, there was still in some wards they were still getting nifedipine or trying to get nifedipine liquid out of capsules, which seemed quite strange in that that is very risky. Really, you've no real sort of reassurance of what sort of dose you're presenting, and again, we can look at an alternative. Amlodipine may be suitable as an alternative calcium channel blocker. Usually, most formulations disperse really well. We can even use a fraction of the tablet, so we can prepare the dose in a liquid form easily for the patient rather than trying to extract liquid nifedipine from the capsule. I thought that practice had gone, but it's still around apparently. Clobazam, that is probably high risk, narrow therapeutic index. I don't think there's any published studies. It's a suspension, so maybe something like midazolam, which is commercially available in some countries, or we can disperse a tablet. Diazepam is actually, most formulations disperse really well. Is that a possible alternative? Maybe in some clinical situations. Dose rounding and dose banding, not a lot of time to go into this, and there's a lot of literature on it, but can we work with our prescribers to say, well, can we get away, can we actually, with no clinical consequence, can we use a dose which is an easily measurable fraction, say, of a tablet? And this requires discussion with our prescribers. You can develop local guidelines, minus the E, must have had a bad day with spelling, but you can work with your prescriber and say, well, we've got this problem with this particular drug or this range of drugs, and we can work to actually come up with dose banding to avoid, if at all possible, the necessity to compound or manipulate a dose form. Just an example there, if you've got a prescription for captopril 14 milligram, dose required, well, in a lot of situations people would tear off and try and if they didn't have the commercial products, make the compounded products using the tablets. But can we actually round that dose down to 12.5 and use half a 25 milligram tablet? If it's a scored tablet, that tablet disperses really easily in water or juice, and that I think reduces the risk that might be involved. Yeah. People might say, well, maybe the dispersion issue is more risky than making up the formulation, but I don't have all the answers, but it's just a matter of looking at the possible alternatives and assessing what you think is the safest option. Crushing tablets, well, there's a lot of literature coming out of this, and there is a project which I think will be published in full soon, and I'm not sure if Katrine is actually in the participants, but the Modric study looked at the effect of dose manipulation and considered the problems with crushing tablets and tablet splitting. And we make a lot of assumptions with tablet splitting that if we split a scored tablet, that we actually get exactly, we split a scored tablet in half, that we get exactly half the dose. Not always the case. Because a lot of tablets are actually, they don't have that uniformity of content. A lot of tablets have a score in them. Mainly the reason there is that so from an adult point of view, the adult can split the tablet into something smaller and swallow it more easily. It's not necessarily in all situations designed to actually produce exactly half the dose. Studies have shown that that's not always the case. So we can crush tablets. We've really got to consider the effects of splitting information, quite tricky to find, and then we can mix with juice or disperse. I think we're all familiar with those issues, but we've really got to consider safety issues as well. If this is being done by patients, and also is it acceptable and safe for the patient. Dispersing tablets, well, yeah, this is quite a good option in some situations. It's best if in a situation where we have got, say, the dose is a half of a tablet, bearing in mind what I've just said about the limitations of a half, but then we can actually, it could even be a whole tablet that the child can't swallow, and we can disperse that in liquid. Some tablets disperse really well. There may be some concerns about bioavailability, but if you look at it, really just accelerating that process, so there shouldn't be major problems. So if you disperse the tablet and then make that into a sort of dose form that can be given right at the at preparation, you don't need to sort of store up any liquids, so that avoids any problems with stability and things like that. We can use a whole dose or an accurate fraction. The formulation brand specific, so different brands. If you know that one brand disperses well, it's not necessarily the case with other brands, so you need to check. And a few hospitals that I've been to, they commonly use pediatric medicines, and of course this extends to use in older people in ICU settings as well, is that they build up a local dispersion guide where they look at the dispersion characteristics of the drugs in use within their hospital setting and actually give an indication, and that's quite useful for nursing staff working in ICU and older care units as well. Again, we've got to consider, is that safe and acceptable? So we can say tablet dispersion is a good option. It may be a good option from the pharmacy point of view, but we've got to consider, can that be handled? Is it safe for the patient to carry out that process? So a lot of considerations. Dispersing, limitations of tablet dispersion. There's very little supporting evidence. It's something that's done, but there's very few studies. Some studies have shown, variability and problems, of course, with, we've got to be very careful in situations where the drug is insoluble. And, if we're dealing with a soluble drug, then it may be acceptable to actually withdraw an aliquot of that. So we've got a dispersed tablet in a known volume of water, liquid. We can remove an aliquot which corresponds to the dose. Again, some possible limitations there, but you could say that will be relatively assured. But if the drug is insoluble, then we're less sure, obviously, because the drug may precipitate out. So dispersing an insoluble drug into a known volume of water and then attempting to withdraw an aliquot that responds to the dose wouldn't be a good option. Essentially unsafe. Oral administration of injections, well, we can do this. There are some guides on the WHO document that Catherine referred to. There are some guidelines on this, but the things really we've got to consider is sometimes the potential excipients within the injectable doses. We have to look, particularly with neonates. We know that things like dexamethasone and indomethacin are actually used quite extensively in this form. And we know also there are quite a few studies where the injection has been used to make an oral liquid rather than the tablet form. There's quite a lot there, but I think the main point there is, we really got to consider what we're giving. If we're giving an injection orally, there's sort of different situations. Is a drug a prodrug, for example? So if we're giving enalapril, it's not going to be absorbed. So the bottom line here is that if we're going to give an injection orally, we really got to be sure that it's actually a good option from a pharmaceutical, pharmacokinetic point of view. Okay, I'll just move on, I think. some general strategies to reduce risk, overall strategies here. Well, I think access is important. If we can put pressure, do our risk assessments, go to the relevant authorities and say we really need these medicines because this is a high-risk product. We've got some evidence to support it. You know, if there's regionally available specials, or if the manufacturing can be done centrally within a hospital setting or a special setup. So a product compounding in a centralized hospital facility where the sort of applied standards would be a good option. Yeah, this is really we can find Coca-Cola and Pepsi. I've put both on there because I didn't want to single anyone out, but we really have problems with access. So I think part of this is lobbying to get better access to medicines. That's the website that Catherine mentioned. As I say, it's looking pretty old and dated there, and I really need to get a professional onto the design characteristics. But we'll be building that up. It is used nationally, and one of the areas which we've started to work on in New Zealand is coming up with standardized batch sheets, so that if a community pharmacist or a hospital pharmacist anywhere in the country wants to compound, so in this case allopurinol, it has a standard strength, so everybody is actually prescribing and dispensing one strength, which is obviously really good from the safety characteristics. Not necessarily that big a problem with allopurinol, but when we're dealing with riskier products from a clinical point of view. There was a case recently published, I think, where there was an issue with a diazoxide preparation that the patients in hospital had received 50 milligrams in 5 mils, and then it was dispensed in a different strength. And the bottom line was that the child received an overdose. So we're really moving towards standardizing batch sheets. If you go to the website, you'll find these batch sheets, so they're not locked within New Zealand, so anybody can actually use these. But the idea is to come up with standard preparation, standard strengths, and get that uniform throughout the country. Yes, one final point, or almost final point, is that really the important issue here is training, I think, and I think the group that's listening this afternoon or this evening, wherever you are, we're all pretty au fait with this. We're all pretty educated, but there's a lot of our colleagues who are not, and that's not just pharmacists, but it's nurses, physicians as well. I think physicians make the assumption that when they prescribe something, a medicine for a child, that it's all done and dusted, and there's no real problems with administration of that medicine. So I think education and training for all people involved, and it really extends to patients as well. It comes back to my point about educating patients about being aware of problems with compounded products, because that openness and honesty will actually increase our ability to manage overall risks, I think. And that's me, and I think we've probably got about 10 minutes for questions. I don't know if that's going to work, Catherine?